Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. Today's episode features Dr. Banu Arun from the MD Anderson Cancer Center, nurse practitioner Marissa Marti-Smith from Texas Oncology, and clinical pharmacy specialist Dr. Allison Butts from the University of Kentucky, UK Healthcare. They will be discussing the role of BRCA testing in adjuvant olaparib in early breast cancer, as well as their experiences with implementation of recent data. This episode is part of a larger educational program titled Current Essential Testing in Early Breast Cancer. For more information on the experts, along with a link to the complete program, including a downloadable slide set, expert commentaries, and other activities and resources, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Hello, welcome to our session where we will be reviewing genetic testing for early breast cancer and its implication on the adjuvant therapy of early breast cancer. I'm Banu Arun. I'm a breast medical oncologist at the University of Texas, MD Anderson Cancer Center, and also co-director of clinical cancer genetics. Before we get started, let's get to know our other team members.
I'm Allison Butts. I'm a clinical pharmacy specialist at the University of Kentucky, UK Healthcare, Marti Cancer Center. I have been doing breast cancer for about 8 years now. I'm also the clinical pharmacist manager for the medical oncology team and happy to speak with you all.
My name's Marissa Marti-Smith, and I'm a adult geriatric nurse practitioner. I work at Texas Oncology at Baylor in Dallas, Texas. I've worked with Dr. O'Shaughnessy for the last 4 years, but I've been working in breast oncology for probably the last 10 to 11 years.
Wonderful. Thank you. So let's start reviewing the Olympia-A study that really set the new standard of care for germline BRCA positive early breast cancer patients. As you'll remember, Olympia-A is a randomized study, 1-to-1 randomization, where patients with germline mutations, HER2 negative breast cancer, after completing all of the therapies, were randomized on a one-on-one basis to olaparib or placebo for a year. The criteria was a little bit more detailed. The authors described two cohorts. One is the adjuvant group, where patients with triple negative breast cancer who were not T1 or N0s or hormonal receptor positive who had 4 or more lymph nodes, or in the neoadjuvant group, again, within the triple negative breast cancer group, the ones who did not achieve a PCR, or in the estrogen hormone receptor positive group who did not achieve a PCR and had a CPS and EG score of 3 or more after completing all of their chemotherapies and surgeries, plus minus radiation therapy, if indicated, were randomized, as I mentioned, to 1 year of olaparib versus placebo. The primary endpoint was invasive disease for survival. The secondary endpoint was a distant disease for survival, overall survival. We will discuss the safety outcomes as well as quality of life related measures. About 920 patients were randomized in each arm, so close to a little bit more than 1,800 patients on the study. The patients were well balanced for their hormone status, menopausal status, prior chemotherapy, as well as their pathological characteristics as it related to triple negativity, ER, PR positivity, and the CPS and EG scores. When the initial results were presented at ASCO that reported the distant disease for survival, there was a statistically significantly improvement in the 3-year distant disease for survival rate. It was about 7.1% with a hazard ratio of 0.57 and a very significant p-value. Now, you will know that very recently, Charles Gayer published the pre-specified second interim analysis of overall survival just a few months ago in Annals of Oncology in 2022 that showed that patients randomized to olaparib over placebo had a statistically significantly improvement in overall survival. The hazard ratio was 0.68, so 30% improvement, with a significant p-value of 0.009. Important also, I think we will come to that when we look at the side effects. Most of the side effects when olaparib was compared to placebo were grade 1 or 2. There was less than 1% grade 3 or greater side effect in terms of nausea, again, less than 2% fatigue, and many other side effects were not statistically different amongst the two groups, slightly more grade 1 and 2 in the olaparib group that related to vomiting, headache, and diarrhea. And more importantly, in the updated safety analysis in the 2022 paper, there were no increased adverse events leading to death. And there was no signal of increased MDS or AML, no pneumonitis. And also, actually, the number of new primary malignancies was less in the olaparib arm. So this was a brief overview, but I want to ask Allison and Marissa, so now with this data in early breast cancer, how are we identifying eligible patients? What was your experience transitioning using this data now in the clinical setting? We have a study that shows overall survival in early breast cancer.
So I think especially with the overall survival data, it's really important that we don't miss people who are eligible. So we're screening a lot more people. I think BRCA testing has become much more in the dialogue in tumor boards and other interdisciplinary meetings like that, because it really does take a large number of people focusing on this to make sure that we're catching all of the patients who are eligible, knowing that the guidelines now say that we should screen patients for BRCA if they are candidates potentially for this therapy. So that's potentially many more patients than previous practice years.
Marissa, how about you in your setting?
I was going to say, for a long time, I think we've always tried to be above and beyond screening patients for genetic mutations, but I think all this data has really put at the forefront is that even more so than normal, we really need to crack down on doing genetic testing and finding these patients so that we can tailor their treatment specifically with a PARP inhibitor if they are eligible for it. So it's just another way that we've been tailoring treatments, but I think it's really helped us be more so mindful of we really have to find these patients and give them this therapy rather than missing patients that may be eligible for it. So I think it's really helped us turn up our genetic screening more so than ever.
I'm curious, who thinks of this in the clinic? ER, PR, HER2/neu is so standard of care. When I see a new patient, my nurse says, oh, Dr. Arun, HER2/neu is not back yet. So immediately everyone is ER, PR, HER2/neu. So are we there with the BRCA testing? Do you think everyone in the multidisciplinary care team, that also includes our nurses, nurse practitioners, maybe trainees, are they all aware? Or does it still fall to us as a medical oncologist to see whether that testing has been done? It almost appears to me like the fourth biomarker that we should be testing for.
Yeah, I agree. I think it should honestly be part of our checklist that when patients come in, we should be doing pathology, genetics, which I think some providers really are very good about doing, but patients still can fall through. But I think definitely surgeons, medical oncologists, nurse practitioners, PAs, I think a lot of us try to review that with everyone that we see, making sure they've had genetics done. But I think it's easiest to find them at the very beginning when they come in to see you guys is probably the most convenient, but definitely patients can get by, or we send them for testing and they never go through and do it. So I always feel like I catch those patients like, why haven't you had this done? You have to have it done for not only surgical planning, but your actual treatment could depend on this.
Yeah, and I do want to say, I think pharmacy has a very big role in this as well, especially, and I completely agree with you, Marissa, that it should be done early on in tumor board or early presentations of the patients. If we're thinking about the entire continuum of treatment potential that's going to be discussed with these patients, I think it's something that's best to think about early and have it on everybody's radar from there. Mm-hmm. But definitely don't think it should be the oncologist alone responsible for this. It definitely takes a village. As you highlighted, the criteria are fairly complicated for who should be included, who should not be. So it takes multiple eyes and ears on it for sure.
Right, definitely. So what are then the barriers that it's not implemented right away in all of the clinics, including community settings? And how can we address that? What can all healthcare providers do to move this forward?
Education is one of the first things that comes to mind. So activities like we're doing right now. As you pointed out, it's not on the minds of probably our nurses, our nurse navigators, our trainees that much at this point. So I think getting word out there is important. But I think a major barrier that's out there is the limitation of genetic counselors. And it's a difficult barrier to overcome at this time. It's not going to happen overnight.
I think not having enough genetic counselors is really an important issue. And here, I think we all have to be innovative and maybe leverage technologies that are available, such as telemedicine, telegenetics, where maybe our counselors can see patients faster and order the testing via the spit kits, for example. That is a great opportunity. We have also started a new program for the lowest hanging fruit for now for all metastatic breast cancer patients and the ones that fit the Olympia-A criteria, where you really do not have to take in-depth family history because the guidelines are pretty straightforward, very similar to the high-grade serous ovarian cancer patients, right? It's now standard of care that they get tested. But because of these more straightforward guidelines, we have implemented a physician order testing, which is where patients don't have to be referred for genetic counseling and wait for the appointment and would not show. But when they're in clinic and the physician provider thinks it's indicated, then order the test. And the positive results are counseled by our genetic counselors via telemedicine. So that system actually can work. Implementation takes some time, but that would be, for example, one way to approach it. We are actively trying that, but I would be interested to hear from you guys. What do you think of that? And if you are implementing similar interventions?
So currently right now, we just order at baseline when patients come in. We'll order genetic testing and we send the referral. Like Allison said, education is huge. Educating patients why they need to have it done. I had someone just the other day that said, well, I didn't schedule anything because I didn't even understand why I needed to have it done. And so I feel like I hear that a lot where patients just don't schedule. They have too many people calling them. And so they're bombarded by all the things that we need done when they first are diagnosed. And so I think it helps. I'm a visual person, so I write stuff down for patients all the time. This is why you need this done. I tell them it affects surgical planning. It affects your treatment. And so I think the more you educate them, first off, the better they feel. But I think then they realize the importance of moving forward with it, the time sensitivity with surgery and treatment. So I wish we had a better process. I think it would honestly be something printed or something we can provide patients to help them visualize their treatment plan that would help them see and check things off when they go through getting all their pre-chemo scans and their genetics. I think something like that would really help people see what they have to have done or what's required as they get diagnosed. But definitely education helps.
I think triaging what genetics need to be done stat versus which ones you've got a couple of months if you're giving new adjuvant therapy, for example, and you've got a while. But even so, it's so easy for things to fall through the cracks because, like you said, they've got medical oncology, they've got surgical oncology, they've got radiation, they've got this therapy, that therapy, and the other. And I think the other paradigm shift that needs to happen with education is people are generally thinking about genetic testing for the next generation. And some people are interested in that, some aren't. So I think really pointing out that this is affecting your treatment today helps to educate patients to make that appointment and follow up with it, because that's something that we've certainly seen some issues with as this has become more prime time.
I've had patients refuse genetic testing because of that. Well, I don't have children. I don't need to have it done. And then I explain, you need to have it done for you. But at the end of the day, they can always choose not to do it. But again, I think if they understand the purpose of it, I think that really helps.
Yeah. And again, that survival data is so key to be aware of and to educate other providers on so that they can share that data with the patients to help them with their decision making.
It looks like it all comes down to education, right, at the provider level as well as patient level. And there's a lot we have to do. Switching the topic a little bit, now that we have olaparib in the adjuvant setting, we have capecitabine, pembrolizumab. How do we sequence everything? I think that having a lot of options is great, but sometimes it makes it also difficult. How do you guys approach it in your clinics? If it's a germline positive patient, of course.
I think part of the complication is that we might not know that information up front when you're designing the entirety of the treatment plan. But I think generally speaking, a lot of these patients, since we're talking about higher risk patients, whether they're hormone receptor positive or triple negative, they're typically getting some chemotherapy up front and then getting the olaparib after that as their adjuvant therapy. I think what's really complicated in what you're outlining is with these different therapies, whether it is abemaciclib, capecitabine, pembrolizumab, how do you choose for some of these? Perhaps olaparib and pembrolizumab are not mutually exclusive. Perhaps we can give those together in the adjuvant space. But certainly if you're trying to choose between one of your other therapies for high-risk residual disease, for example, it's complicated. And I think you want to look at the data critically and figure out which option gives your patients the best chance. At this point, we don't have a lot of options of continuing these therapies together, or even do you sequence? Do you give 6 months of capecitabine and then give olaparib or vice versa? We just don't have data to support that at this point, and that makes it difficult.
That's why I was just going to ask you, Dr. Arun, how do you decide? Because it is complicated.
It is. As Allison said, it's really individualized. Again, hopefully and ideally we have this information available up front. But for example, if I have a triple negative breast cancer patient who received neoadjuvant chemotherapy and did not have a PCR and has residual disease, and if she had the Keynote 522, I think it really makes sense to continue with the pembrolizumab. You can do it either sequentially or together with olaparib, because again, we have overall survival benefit with olaparib. So I would never give olaparib up. The question is whether you want to finish the pembro 6 months and then do the 1 year, or do it together, the 6 months overlap, and then do the remaining olaparib for 6 more months. I have personally a harder time adding the capecitabine on the top of it. So then that means almost 3 years of adjuvant therapy, which we have no data for. And I acknowledge that the CREATE-X trial did indeed show benefit for capecitabine, but that was one study. And when you look at the recent meta-analysis, the amount of benefit was not as exciting as what we saw in the CREATE-X. So when you put all of the studies together, for the post-neoadjuvant, I think I would do the pembro and olaparib together or sequentially. In the adjuvant setting, again, how to do it with abema, that's a big problem because there are some early studies showing that CDK4/6 inhibition plus PARP inhibitors are rather cytotoxic, so they cannot be used together. And here we are talking about 2 years of abema, 1 year of olaparib. That's another 3 years of therapy. Knowing that we have an overall survival benefit, we have the hazard ratio for olaparib in germline BRCA positive patients, since we have a study in this population, whereas in the adjuvant abema studies, we don't know about the BRCA subgroup. I think I would, in that case, favor endocrine therapy, of course, plus the olaparib, and maybe not entertain the CDK4/6, but we have no data, as you guys have pointed out as well. Yeah, but together would be very difficult. I would not recommend that.
I think something that's worth pointing out for the purpose of this podcast is this is still a rare condition. We're talking about 5% of breast cancers having a BRCA mutation. So it's hard to get a ton of data with some of these combinations because it is a rare condition that isn't the easiest thing to study. It's a limited number of patients.
I think too, we didn't talk about it, but the more I hear about all of these adjuvant therapies like abemaciclib, capecitabine, olaparib, these are adding on time to patients' treatments. I think the more we know this ahead of time, the more patients are prepared. So again, being the benefit of finding their genetics at the beginning rather than later, because telling a patient, oh, you actually have another whole year of therapy, even if you tell them all the data, they may not be at the point where they want to do that. So I think the earlier we get this and tell them, oh, this is another thing to help improve your survival ahead of time, then they're more prepared to have that towards the end of their treatment.
Yeah, and along those lines of this being a long course of therapy, I guess we can move into talking about tolerability and how patients are handling this treatment. So Dr. Arun, do you want to comment on how your patients seem to be dealing with the olaparib side effects?
That's a good question. Of course, this is new. I don't have personally tons of patients who after the approval, finished all of their therapy. So they are either there or I have one or two patients. My most experience really comes from the metastatic setting with single agent talazoparib or olaparib. For the single agent data purposes with olaparib and talazoparib, we have treated a number of metastatic breast cancer patients, and we were not surprised with unexpected side effects other than what was reported in the literature. Now we know that talazoparib is a little bit more toxic, more thrombocytopenia, more anemia. I think it's because it's a PARP trapper. With olaparib, we don't see it that much. I do not recall having to either take a break or dose reduce or transfuse a patient, give either platelets or packed red blood cells for our metastatic patients. And many are pre-treated, but they still tolerate it well. For the few adjuvant patients, they are really doing well. I have not had any side effects. Now, this one patient I started right after Pembro, so I don't have the combination. So therefore, I didn't see any side effects that maybe was increased because of the doublet. But I'm curious to hear whether you guys have experienced any unexpected, unreported side effects other than what we know from these studies.
For adjuvant olaparib, I think we've only had maybe a small handful that we've started recently, and I haven't seen them. Most of my experience with olaparib's been in the metastatic setting, which, like Dr. Arun mentioned, it's a little bit different if these patients have been heavily pre-treated and may have other issues in general. But overall, really, in the side effect profile, I think patients do fairly well. I can't think of anything specific in terms of issues other than the nausea tends to improve after the first month or two. Sometimes the fatigue can be bothersome, again, but those are in metastatic patients that have probably had multiple lines prior to that. So I haven't seen as much of that as an issue in the adjuvant setting. We monitor their blood counts closely for sure the first 2 months, but then monthly thereafter for the most part. So most people tolerate it fairly well, I feel like.
Yeah, likewise, we've had a limited number of patients start on the adjuvant use of olaparib, but no new safety signals. I think mild nausea, that's handled with PRNs. I haven't even had to schedule antiemetic pre-medication with it yet. No major issues with anemia. And again, like you were highlighting, a lot of these side effects happen fairly early on. So I think if we've not seen them in the first month or two, that's pretty good news for the future. But it seems to be well tolerated. I would say fatigue certainly is the biggest factor, because even though they're not as heavily pre-treated perhaps as some of our metastatic patients, they are coming out of neoadjuvant and or adjuvant therapy. So they're still pretty fatigued, still ready to be done with us.
Right.
Recovering from surgeries, radiation therapy if needed. And even with endocrine therapy, if it's a premenopausal young patient, we know just ovarian suppression and an AI. I mean, we have the studies, right, where we are discussing balancing the side effects with the outcome benefit. And then now we are introducing another drug. So these patients already have, these premenopausal women already have the ovarian suppression side effects and the arthralgias, myalgias, comes with fatigue. And then we are adding on olaparib to that. So understandably, it is maybe easier than in patients with metastatic, but a different toxicity profile because of the other medications they will be on or surgeries and radiations they've had recently.
I think knowing that this is now perhaps their first oral medication that they're managing at home with the fatigue and some of those side effects, it's very easy for patients to cut back on their dose, skip some doses, that to help themselves along. So it's really important, again, as we've said, to educate the patient about the benefits of this medication and ways to make it more tolerable. Right. But it is hard when you cross into that self-managed therapy step after however many months of IV therapy.
I think we really need some studies that is looking at maintenance and drug adherence. We've done studies in DCIS and prevention, or even in the adjuvant setting with endocrine therapies and AIs. I think it's very important that we collect the data sooner than later for the adjuvant 1-year olaparib, where, as you mentioned, they are taking it home. And which one are they skipping? They're skipping the endocrine drug. Are they skipping the olaparib? And how often do they skip it?
No, that'd be very interesting to see.
Well, thank you very much. We discussed a very important topic today, reviewing for the first time improved overall survival data in a specific subgroup of early breast cancer patients, namely the germline BRCA positive patients with an oral drug, a PARP inhibitor, after patients completed all of their appropriate neoadjuvant or adjuvant therapies, including surgeries and radiation therapy.
Thank you very much to our multidisciplinary specialists, and thank you to the listeners for joining us. As a reminder, to view the full program, current essential testing in early breast cancer, and to access additional resources associated with this program from the website, please click on the link in the show notes. As always, thanks for listening.